All right, welcome again. Now that folks have some cookies and drinks, I want to go ahead and welcome our speaker for today's event. My name is Elias Bakhtiari. I'm director of the Schroeder Center for Health Policy, and very excited to welcome our speaker today. Dan Skinner is a professor of health policy in the Department of Social Medicine at the Heritage College of Osteopathic Medicine at Ohio University. He's also currently editor-in-chief of the journal World Medical and Health Policy, and he's published many articles and books on a wide range of important health policy topics, including the opioid epidemic, the politics of medical necessity decisions, community health centers, just to name a few. His most recent book, titled The City and the Hospital, examines the complicated relationships between large urban health systems and their surrounding communities, which we will hear more about today. Please join me in welcoming him to William & Mary.
Thanks very much. You can all hear me okay? That's good. And by the way, with the refreshments and the snacks, please just get up and get them whenever you need. We can keep things flowing here. Definitely don't want to leave too much at the end. So enjoy that. And thank you to Dr. Bakhtiari and the Schroeder Center for having me here. It's been a cool 36 hours kind of seeing Williamsburg and getting to meet really interesting and smart people, students, faculty, others. Very cool, a really a big treat for me to be here. And also to be able to share with you a little bit about the book that I recently published with two of my colleagues. I also just want to say, scheduling-wise, unfortunately we have to head out of here to the airport a little bit at the end, but I really mean this sincerely to those of you who are here, those of you who might be watching the recording. My email address is there. I welcome hearing from you. I'm happy to, answer questions. I don't know, whatever you need. I'm a medical educator. I'm an educator. I enjoy supporting people and building my own network of smart people and helping in any way I can. So please don't hesitate to reach out. I welcome hearing from you. Let's see here. So how does this little thing work? There we go. Okay, good. So I want to talk to you a little bit, just talk through a little bit about the book, and we'll have ample time for questions and answers. As I mentioned, it's co-authored by me and two of my colleagues, both of whom are sociologists. I'm a political scientist, although now I'm a health policy professor. So one of the things that you learn as you get interested in questions is you sometimes find yourself breaking disciplinary boundaries and not worrying about it so much. 20 years ago, to the students in the room, I wouldn't have recommended this, but I think it's becoming more and more common to just think about questions and problems and address them and then find the tools you need, even cross-disciplinarily. So it's just something to keep in mind. It's a 3-city study that we put together, and we spent a good deal of time in each one of these cities, in Cleveland, Aurora, and in Hartford, Connecticut. We conducted over 200 interviews. It was a lot of interviewing, a lot of time spent with a wide range of people, and just a real joy, to be honest. Interviewing is long and hard, and coding and transcribing and all of that, but sitting with human beings in their living rooms, in their offices, for walks on streets is really something that it teaches you things about places that you can't learn any other way. And we interviewed residents, health professionals, law enforcement officers, local business owners, all sorts of different people. And that's one of the ways we were able to learn what we needed for this book. We also did, as appropriate, we supplemented our interviews and our qualitative work with health data, other kinds of urban data, to try to get at the questions we were looking at. In selecting the sites, we thought about a couple of different sites, and to those of you who are interested in doing research, maybe there's a little bit of a lesson learned here. As I'm going to talk about in a moment, hospitals are among the most tight-lipped. I don't want to be too dramatic because people don't use language carefully enough in our world, in my view, but I will say even paranoid institutions in the United States. Hospitals are extremely hard to study because they have become large, very tightly controlled corporate entities with archives that may or may not be available, and access may be differential. For example, some of the hospitals we studied were kind of like, hey, come on in, here's a bunch of people. Others ignored us for months until they heard that we were around and we were persisting, and then finally returned our emails. And then even then required that we be with PR people and, tightly controlled and monitored the entire time. So you're going to get these different kind of levels of access, and we write about that, and it's not exactly a limitation of the book, but almost a finding, is why have these public and nonprofit entities become so hard to ask very basic questions about. We were also looking for regional diversity, so obviously Colorado, Hartford, and Cleveland are different kinds of places, but obviously that also means there are some areas that aren't represented in our study. But I will say, one of the things I encourage you to do, and I'd really like to hear from you in Q&A, is your own hospitals, your own locations. I tried to get a little bit of a sense of what's going on here in Williamsburg with healthcare systems. But no matter where you are, hopefully this book will offer you a framework for asking certain kinds of questions about hospitals that may be different from the ones that certainly the hospitals want you to ask. They want you to know about the U.S. News and World Report rankings. They want you to know that they're number 2 in ophthalmology or whatever. We ask a different set of questions beyond that. And finally, we wanted to have different kinds of hospitals involved, and I'm going to tell you a little bit more about that in a moment. So the title is obviously a bit provocative, turning with a play on the idea of being medically underserved, which may be familiar to most of you here. It's a federal classification for underserved communities that are encumbered by certain conditions: fewer primary care providers, high infant mortality, high poverty, and a high elderly population. But also this changes from time to time. But our animated question was kind of, backing up from the details of hospitals and, the financials and all of that, is really just an observation we had, which is it seemed to us that many neighborhoods right outside of U.S. hospitals, and not small hospitals, not low-income community hospitals, some of the most prestigious institutions in our country, seemed extremely poor. And also, we started looking just preliminarily at health data and noticed that they were health poor as well. So why is this? Why is this? And we also kind of wanted to know, do the hospitals notice this? Do they talk about this? Do they care? And also, just why, right? But beyond the sort of observation that these neighborhoods often, and I don't want to overgeneralize, there are hospitals in wealthy areas, and we could talk a little bit about that, because hospitals relocating from poor and health poor areas to wealthier suburbs is also a trend in the United States. There was a big example of this in my home city of Columbus, Ohio recently. But we actually wanted to go a little further, which is we were wondering whether hospitals in some way contributed to this, or even caused this, to be a little bit more direct. So we know hospitals do wonderful things. They save lives, they take care of people, they deliver babies. People have good feelings about hospitals oftentimes, especially when things go well. If they don't go well, it goes the other way. But we kind of wanted to bracket all that and ask, what kind of entities, what kind of urban phenomena are hospitals, right? And what does that mean? So, in recasting them in this way, I just want to emphasize again, because I teach medical students and I've learned giving lectures for years that I'll try to say, hey, I think physicians are fantastic, they do important work and all this kind of, and I say all of that and then I give them the other side of the story, and all they hear is the other side of the story, and then I get my teaching feedback and they say, why does Skinner trash doctors all the time? That's not what we're doing here. We fully, readily admit that a great physician can change lives, that a great physician and other health professionals and nurses and PAs and all the people who work in hospitals, they do great things. But we wanted to ask sort of, what if we looked at them from a little bit of a different perspective? What would we see? There's another way to look at hospitals, which the more sort of cynical, I shouldn't say cynical, that's mean, especially because I know we have some economists in the audience here, but there's a way to look at hospitals, which is just purely from an economic perspective. And I'm here to tell you that if you do get the ability to talk over a cup of coffee or a glass of wine with a top healthcare executive, you will hear them talking about bond ratings, and you will hear them talking about financials in a way that makes it clear that there are entities within hospitals who look at hospitals as just a pure economic force, right? And maybe that's their job because they aren't in this to go out of business tomorrow, and some of these entities are billion-dollar entities. But to those of you who may be part of the common concern about the state of American healthcare, you may ask the question, where are patients in all of this, and where are health outcomes, and where is population health? And there is a way to look at these entities in that way. One of the ways you'll hear increasingly is the line, and it's true, that in most major American cities now, the healthcare institutions, especially the healthcare systems, are the #1 employer now. Right? And that didn't used to be the case. You'd have lots of manufacturing industries in a lot of American cities, especially large-sized Midwestern cities and such, where, but hospitals have really displaced a lot of that. I commend to you Gabriel Wynant. He's a sociology, his book called The Next Shift. If anybody from Pittsburgh here or know a little bit, yeah. So Gabriel Wynant's book is about UPMC in Pittsburgh, and it's a fantastic book. And he asks the question, because if you talk to the healthcare systems, they say, isn't it amazing we're the #1 employer in Pittsburgh? And what Wynant says is, no, it's actually a little concerning to me. And he details the reasons why the healthcare workforce is a different kind of workforce than some of the jobs and the industries that used to sustain cities. So there's that. Then there's just the fact that it's true. If you talk with the Cleveland Clinic, they'll say, look, we are the #1 economic driver in Cleveland. Well, that's a great thing from some perspectives, but it also might concern us in others. Hospitals also, beyond the healthcare services they provide and what we know they do, they also expand, they relocate, they have a lot of pull. If you're the #1 employer, if you're a large economic driver in a city, you can have transportation systems rerouted. You can have highways rerouted. In my city of Columbus, Ohio, the Children's Hospital, which is expanding and expanding, led to a major highway restructuring to accommodate their expanding campus. And as we know, the expansion of the interstate highway system has a long history of displacement, of disrupting neighborhoods, wrapped up in powerful and not powerful groups, has a correlate with racial politics, and local businesses and schools and residents are in the middle of this. Right? So once you start looking at hospitals as urban phenomena, you can start to ask questions about, well, what kind of force are they within cities? And that was one of our key questions. So a quote from our book I just wanted to share with you. The book explores how hospitals can become true community-focused entities, not by medicalizing and controlling the local community, because that's a concern, right? But by collaborating with the community to improve health outcomes and to reduce social inequality. There are a bunch of different moments, reasons why this question was ripe at the time when we started asking these questions. Obviously, Congress had passed the Affordable Care Act in 2009, right? And the Affordable Care Act started to become implemented. And one of the pieces that most people didn't talk about, for example, when President Trump was focused on repealing the ACA unsuccessfully, was that community benefit provisions that the hospitals were required to do all sorts of new things under the ACA, and that would have gone away as well. So that was one of the sort of pieces that defined this moment in my view. The other was that there was just increasingly, and those who are a little bit older in this room will remember, all of a sudden everybody was talking about social determinants of health. We were looking past biomedical models and pure clinical models and starting to think about things like housing and food. And it was a real new discourse in some ways. I mean, it had kind of been around since the 60s, but it started almost becoming so prevalent that I wondered if people were hearing the radicality of what we were actually calling our attention to. Certainly, when some of the largest corporations in the United States started talking about social determinants of health, you have to realize that moment might be over now. It's been co-opted and watered down and all of that. But it was true that people were asking questions, and hospitals were as well. We also started to realize, and this shapes, again, I'm a medical educator, so I work with a lot of physicians and I train future physicians, but we were starting to come to terms with the fact that the future of addressing health inequities, the future of addressing structural determinants and social determinants and political determinants of health and all these new frameworks was not biomedical. The physicians and the health professionals were not going to lead the way in doing this in their exam rooms, but they could if they became part of broader conversations, and there started to become pressure on hospitals to become part of this new conversation. Okay, so we're now focusing on strategies that are much more expansive, and whether you're looking at Johns Hopkins and you probably know Henrietta Lack's story, right? A lot of attention on Johns Hopkins and its history of racism and some of the things that it wanted to, that it thankfully because of pressure started to wrestle with, called for hospitals to move beyond their campuses and to start to see themselves as more integrated into communities and having responsibilities. Real quick snapshot, our three hospitals. I just want to make sure you understand a little bit about them, because they are slightly different. University of Colorado Hospital in Aurora. One of the things that's really interesting about the Aurora campus is that it serves a 5-state region. So when we think about who is the community you serve, there's a constant flow of helicopters in from all these states all around, from Kansas, from Wyoming, right? I mean, it's really a regional center, which when you think about what that means for local communities, you have to ask, where their focus is. Interestingly, with the University of Colorado Hospital, they were originally in downtown Denver and wanted to expand because these modern hospitals, they all want to build specialty centers, they want more bed capacity, they want a whole bunch of things. And the local community in downtown Denver, comparatively a pretty affluent community, predominantly of professionals and a white affluent community, mobilized against them and said, no, we don't want you to expand. So they kind of hit this wall of powerful constituencies that kept them from expanding and developing in the ways they wanted, which then sent their focus to Aurora down the road. If anybody knows this area, it's a couple miles down the road, to a area where there was a former military base that had closed down and they were looking to revitalize it. That became the Anschutz Medical Center, which is now the Children's Hospital, the University Hospital, medical education facilities, and a Veterans Administration hospital as well. So that's kind of the context there. Hartford Hospital, been around forever. I mean, it's a very old, New England hospital dating back to the 19th century. A top-ranked place, primarily a teaching hospital. So one of the questions we're going to have is training physicians, does that count as community benefit and giving back? Where should that fit into the mixture? And I'm happy to talk a little bit about some of the conversations around training the future workforce and how we should think about that. It's located in Hartford's South End, especially in the Frog Hollow neighborhood, which is a predominantly Puerto Rican neighborhood. It's adjacent to a children's hospital there, and there's going to be more to say about their expansion and their efforts, but it's a little bit of a different context than we had in Aurora. And then there's the Cleveland Clinic, which many of you have probably heard of. When my certain administrators in my college found out that I was studying the Cleveland Clinic, they were not happy about that, because the Cleveland Clinic is a major entity within the state of Ohio. Also, we have a campus. One of our 3 campuses is in collaboration with the Cleveland Clinic. They were the entity that refused to take our phone calls and took a while to gain access. Very brand conscious, just everything very, very prescriptive, very, very carefully controlled. Obviously, extremely famous. They are one of, if not the top place to go for cardiac care in the world. a renowned research focus, a global footprint. So you may know the Cleveland Clinic, which is a nonprofit entity in the state of Ohio, right? Nominally for IRS purposes, a nonprofit entity, but with billions in revenues. There is also a Cleveland Clinic, Florida. There's a Cleveland Clinic, Abu Dhabi. There's a London campus, right? Those are all for-profit operations. So it's a little bit more complicated when you think about which of these entities is classified as a nonprofit with obligations to communities and which ones of these are for-profit operations. And I can talk a little bit about how to think about for-profits and nonprofits if you're interested in that. But the Cleveland Clinic had a really long documented history of strained relations with its local communities, especially if you go online and you read about Huff, the neighborhood of Huff in Cleveland or Fairfax, but especially Huff. There were, right in the middle of the civil rights movement in the 1960s, there were some uprisings, long history. When we talk about the lack of trust amongst African Americans in the medical world, this is ground zero for that kind of thing. Long time talking about the patient dumping and sort of refusing Medicaid and, lore about hiding their emergency room. They got yelled at one point because it was pretty clear they didn't want people to find their emergency room and they weren't using signage in the way that it was expected of a nonprofit entity. So once you start asking these questions, hospitals become really fascinating places with a much deeper story to them. But still, if you have a serious cardiac condition, you want to be at the Cleveland Clinic, right? And that's one of the contradictions in all of this. So just a couple things about hospital-community relations in general. Looking at structural conditions is really important, and I was informed last night that I might not be understanding redlining exactly in exactly the right way that others do, but we hear stories about neighborhood segregation and how neighborhoods have developed, and certainly hospitals are wrapped up in that history in a very clear way. I mentioned the interstate highway system. Anybody who's studied the development of the interstate highway system or learned about Robert Moses and some of the work that he did in Robert Caro's famous book on Robert Moses. I mean, the laying of the interstate highway system in the 1950s was extremely important to the design of cities as we know them today, but also extremely disruptive. And certain communities had the ability to have highways diverted and around them. Other communities with no political capital or a little political power were divided and chopped in half. In Columbus, Ohio, there's one through I-70 that runs through the center of our city. There's a street, and if you go there still today, all of a sudden there's two houses in the middle of nothing. And it's kind of amazing to me because those two houses got left behind when they drove the highway through, separating that neighborhood. So when you look at neighborhoods and just go on maps, you can ask your question, well, what was there before the highway was built, and what kind of political conversations must have happened leading to the ultimate outcome of where it was placed? History plays a really important role in this, and a lot of what we did in this book was just really storytelling. And a lot of our interviewing was focused on just hearing people's stories about what it's like to be there in that community, what their experiences with the hospital have been, and that's where you see a lot of trauma. That's where you see a lot of the medicalization or racism or experiences that people had in emergency departments, but also things they've heard. And there's a lot of stories that circulate within communities that you may even do some fact checking on it and find out that the story is is partially true or not, but it still shapes local communities' understanding of these entities. And a lot of what hospitals do from a PR perspective is wrestle with this kind of circulation of discourse in local communities. In most cases, when hospitals, the ones that we studied, and now if you look around at any hospital, I guarantee you almost all of them are doing some kind of outreach work that fits into the category that we describe in this book, you'll find animating events or crises that led to a problem. So in Columbus, Ohio, Nationwide Children's Hospital where I do a lot of work, research work, there was a story in the local newspaper that called the hospital slumlords because they owned a bunch of property, and there was a question of whether whether they're gentrifying the community or whether they're their rental practices were not good, and that pushed the mayor to make some comments. So hospitals are really concerned with their reputation, if above all, and the kind of local stakeholders put it to the hospital leadership and said, look, either you're going to leave or you're going to stay and you're going to work with us, and kind of using that local activist leverage to raise these questions. Like many of these programs, I mean, if you remember Bill Gates has gone on to become one of the biggest philanthropists in the world, right? If not I don't know. But those of you who are a bit older and can remember, Bill Gates got into that because of antitrust challenges that were sort of a really big PR problem for Microsoft and for Bill Gates. Now, it turns out that Bill and Melinda Gates now love philanthropy and are super into it, but they didn't jump into it for fun or because it was they came to love it, but they were forced by a precipitating event, right? And frankly, by the imperatives of public relations. There was a large fire that took place in Hartford Hospital. That's part of the history there that shaped the community's understanding. Another thing in a more positive way, well, I shouldn't say that, that's not what I mean, but you may remember the Aurora shooting in the movie theater. As the hospital system that had just moved into that area was having trouble ingratiating itself with the community, it was able to demonstrate its ability to help during that crisis. And that's widely regarded as a key moment in the Anschutz Medical Center when they could see the good that the hospital system could do. So that horrible, tragic event became important to the history of how Anschutz has become increasingly well regarded. And the Cleveland Clinic, as I mentioned, has a long history of these kinds of things that it's had to negotiate. And then there are these implicit and explicit strategies. So the explicit strategies will be things like programs. I'm going to talk a little bit about them in a moment. But the explicit programs, outreach efforts, whether it's sponsoring farmers markets or doing remote clinics or involved in improving housing stock, those kinds of things. But then there's a lot of sort of strategies where community-mindedness is kind of ingratiating itself in the way hospitals behave. And I think that's a really good sign that there is a kind of cultural norm changing within that I think we see more and more. And as I mentioned, one of the things, and as you know, if you study the American healthcare system, you will know that healthcare systems are consolidating, that there is a trend of large systems buying up community hospitals, probably making changes to them, sometimes shutting them down, but certainly every large medical center in this country has expansion plans, whether it's opening up some new center, increasing bed capacity. COVID really made us rethink a little bit about some of the bed capacity decisions we'd made in the past. Expanding is difficult business within the context of urban development. Right? Some hospitals, I would venture to guess most of them, I'm a baseball fan, so I'll use the metaphor, lots of swings and lots of misses in trying to expand in a way that that doesn't anger the community. Right? Lots of, well, we posted a plan and we had a meeting here and we invited you and nobody came, so we just decided to go ahead and build this parking garage behind your houses. Or other stories too, and I could share some more of them. But lots of hospitals are sure that they did community outreach only to find out that the community that didn't work. So that's that kind of institutional mentality that's not really listening to the community and finding out what would be good outreach, but kind of acting and then apologizing and constantly having to renegotiate. So expansion is obviously something important here. Okay. So when we think about hospitals and health outcomes, and again, I don't want to overstate There are going to be lots of examples where I'm sure you can find out that what we're talking about doesn't apply. There are hundreds and hundreds of hospitals, actually there's thousands of hospitals in the United States. So we have to be fine-grained with it. But I've already kind of shared that this was sort of one of the animating ideas here. It's just, what is the relationship between a hospital and poor health? Because at a baseline, you would assume that people who live within eyeshot or within a certain proximity to a hospital would have better health than people who don't, especially around access to emergency departments or, with pediatric issues like asthma or that kind of stuff. And it turns out not always to be the case. But the question is why? Why is this? And I've already suggested that there can be a bunch of different ways to look at this. Okay, let's bracket this for a minute, and I'm going to get back into the discussion about hospitals and communities in a moment, but let me just do my due diligence and make sure you understand a few key legislative developments. Most of you probably know at least most of these. The first one, which is a little bit obscure, but I encourage those of you who love history, and history is a key here, is the Hill-Burton Act of 1948. The Hill-Burton Act was a groundbreaking act, the first time when the federal government invested a lot of money in the building of hospitals. A massive infusion of cash post-war into American hospitals. Great thing. One big problem. Anybody know what it is? Anybody know the big problem with Hill-Burton? It explicitly authorized segregation in American hospitals. So again, a very 1948 kind of thing, right? Large infusion, big moment for infrastructure development, but also sort of licensed and reiterated that American hospitals could be segregated and that their policies did not have to, provide equal access. Secondly, 1964 Civil Rights Act. And one of the things that people don't talk about the Civil Rights Act is the way in which it undid a lot of what Hill-Burton did. So the 64 Civil Rights Act, because if you've ever studied the Civil Rights Act, you know that it took a bunch of years for a lot of its provisions to take hold at all. Okay, but the desegregation of hospitals was a pretty major development in the history of the American healthcare system, and I encourage you to read about this. If you ever read Paul Starr's book, The Social Transformation of American Medicine, he talks about this and lots of others. I think I wrote a little piece, if you search for it online, about Ohio, because either Hill or Burton was an Ohio senator, so those of you who care about Ohio might look that up. In the 1980s, we have the Emergency Medical Treatment and Labor Act, EMTALA, which I'm sure those of you who study healthcare have come across. This is this amazing moment during the Reagan administration, and we always got to remember, because it's controversial, the Reagan administration, when legislation was passed to ensure that all hospitals receiving funding from Medicare could not turn away patients at least to a point of stabilization. So they're not going to go in there and get the best care or follow up or stay for days, or we don't know if they're going to be able to fill their prescriptions and that kind of thing. But it was a pretty major development in the idea that hospitals in receiving federal funding had responsibilities to patients. And also, still to this day, I mean, if you remember the election with Mitt Romney and Barack Obama, this came up, this question of should we turn people away who don't have insurance? I mean, the ACA debates were right in the middle of this. And EMTALA still holds. And I sometimes, when I get cynical and depressed about some of the things that we haven't been able to do in this country, to me that's a baseline that we have not undone EMTALA and that there's really no taste for that kind of thing. I think it speaks at least to some floor, although politics. We always have to be open to the possibility that the floor could be lowered. And then finally, the Affordable Care Act, passed in 2009, 2010 officially, and major landmark legislation. One of the things that, especially to the students in the room, I mean, I guess 2010 for those of you might be distant past, from 2010 until 2018 or so, the entire conversation was about, since the election of Donald Trump, it was is the ACA going to go away, and what does that mean? Like, what are the alternatives? We drove down the uninsured rate by a heck of a lot, but as we learned, no clear alternatives came to the fore. Senator Mitch McConnell kind of said at some point, we got to say, we're out of this business of repealing the Affordable Care Act. And so the Affordable Care Act has kind of become ingratiated and part of the scenery. I mean, there still may be some challenges to it or around the edges, and maybe someday I'm going to have to eat this recording when I say, where we are. But in general, the ACA has become less and less controversial, and we've turned to other things. But one of the things, as I mentioned, that we haven't really talked about with the ACA is what it called upon hospitals to do, and the way it changed our community benefit expectations. So a couple of things just on a brief history of community benefit. This has been around for a long time. For nonprofit hospitals that are not paying the vast majority of taxes that a for-profit or other entity would be paying. Because keep in mind, we forget with nonprofits that if you look around an American city, like I remember somebody in Hartford took us for a walk, and at one point it was trying to show us how little within this city of Hartford was taxable. When you remove state government, county government, local governments, education facilities, parks, entities that have gotten tax abatements for various reasons in development, and hospitals, all of a sudden the taxable land within a city can dwindle to a very low number. I forget what it was, but it was below 50% of the land in Hartford could generate any tax revenue, which means you look at schools and they're failing and you're wondering, why is there not enough money to pay for this or that? So when we're talking about a hospital or any other entity becoming a nonprofit, we need to ask, based on the revenues they have coming, if they were paying taxes, how much of a cash infusion would that be into local services and supports within cities? And look around any American city and ask yourself, what's generating revenue here for the schools? What's generating revenue here for other services that we provide? And I think you'll be a bit shocked at how much is actually left. So classifying something as a 501c3 nonprofit comes with a cost. But from the 60s on, even earlier, charity care was the main thing we looked at. We said, look, hospitals, you just need to be providing charity care. Don't be overly aggressive in going after people for debt, for medical expenses, and provide free care for those who can't afford to pay. And we'll basically look the other way, and not ask too many questions. But as healthcare became a bigger and bigger industry, and things became, these entities went from, community hospitals to something like the Cleveland Clinic with billions of dollars of revenues and what we might call profit, but we don't because they're nominally nonprofit. It's a lot of money. And increasingly since the 90s and then into the 2000s, senators and Congress members started looking at some of these entities and asking, well, what's going on with them? The other thing that happened around the ACA that made community benefit more of a focus was the fact that, and lots of criticisms of the ACA, I'm not like an ACA zealot, but I try to be pragmatic about healthcare, and especially in this political climate, was that it drove down the number of uninsured people, which means a lot less charity care coming out of hospitals, a lot less free care, even in emergency departments. Emergency department, people still went to emergency departments, but they often were paying through, because of Medicaid expansion or other mechanisms within the ACA. Hospitals appeared a little bit different. In fact, if you study the local hospital associations, I don't know about Virginia, but I can take a guess about this. But certainly the American Hospital Association, this was not an enthusiastic supporter of the Affordable Care Act. In fact, they opposed a lot about the Affordable Care Act. And then it became law, and then what happened is they kind of changed their tune once we saw how it worked out. And how it worked out is that uncompensated care in American hospitals was driven way, way down. So all of a sudden the hospitals, when Donald Trump was elected, and trying to repeal the ACA, most of the hospital associations were vocally opposed to repeal because their uncompensated care had already dropped so much. But if their uncompensated care dropped that much, what are they doing for their nonprofit status? What are they doing to give back to the community? Because it ain't charity care so much anymore. The ACA introduced a few new concepts, community health improvement. So we're not just talking about charity care and providing care, like the clinical side of things. We're talking about hospitals improving the communities they're in, and what's called community building, actually increasing the capacity within local communities. So the ACA took a big swipe at this, and I wanted to make sure we understand this really well here, because there's pluses and minuses here. But in broad strokes, the ACA requires, and it introduced a new tax document that you have to fill out, that these nonprofit hospitals had to fill out. They had to conduct community health needs assessments, first of all. Now, there's a number of different ways they can do this. They can do this on their own. They can contract with a company to help them do it, in consultancy firms. They can do it in collaboration with public health associations or departments. And they can also collaborate together, and actually a lot of hospitals around the country now are collaborating together on these, which is, I think, a pretty exciting thing. So they have to find out what are the needs in the community, and they have to do this every couple of years, every few years. And from that, they have to devise a plan for addressing community needs, okay? And they have to prioritize their plan, too. One major disconnect here that I want to call your attention to that's kind of curious, and I can tell you why, but it is curious, is that the plan for addressing the needs doesn't need to reflect the needs they discovered in the health needs assessment. In other words, they can say X, Y, and Z are the major things that the community is concerned about, that's driving down health or whatever, but we're going to focus on these other things, okay? And they do have to invest in programming, but it's not clear how much. Now, some senators and Congress members you talk to about this will say, well, it should be the amount that they're getting in terms of tax benefits. They should give that back to the community. But there's not really tight control over this, and there's not really much of a detailed regulatory framework that's requiring this. The reason why this is kind of vague, and actually I talked to a lot of hospitals who say, yeah, we wish we had more guidance from the Obama administration. The reason why is because if you remember the ACA debates, they were trying desperately not to be seen as being overly aggressive and regulatory. They were trying to be deferential, even though it didn't really work. The Republicans still raked them over the coals for this, and they didn't get really credit for being like, well, the Obama administration is being really flexible and all that. But they left a lot open to provide flexibility, but what ended up happening was that not nearly enough was done. These hospitals could kind of like massage this in their documents. And also some hospitals didn't know what was even expected of them. So the ACA's community benefit requirements were a little bit too vague, a little bit too weak. And that's one of the things that I think is going to come in the future. And I haven't heard, I mean, Kamala Harris is not going to be able to really talk about detailed things like community benefit. And we know where Donald Trump stands on the ACA, but I'm guessing that over time we're going to start hearing more about this. So the ACA underspecified the process. Okay, briefly, just on the book, a couple concepts I want you to know. One is this idea of contact zones. Now, I'm a political scientist. I worked with two sociologists. They were aware of this concept. This is one of the reasons why you collaborate with smart people, right? Because they teach you things. And if you're not hanging out with smart people, I suggest you rethink that, because it saves you a lot of time and expands your world. But this idea of contact zones that comes out of the work of Mary Louise Pratt, which I believe she's an education scholar of some sort, where different cultures meet, clash, and grapple with each other, and also points specifically to asymmetrical relations of domination and subordination. Now, the reason why this is important is because hospitals clearly are this, and specifically emergency departments are these kinds of places. The vast majority of people we interviewed in communities, insofar as they had a relationship with the hospital, it was through the emergency department. And if your welcome mat is through the emergency room, like that's not going to go well in most cases. We know the story of American emergency departments, and the long waits and some of the conditions. I will tell you that, I mean, again, training medical students who haven't even yet become physicians, they're already filled with lore of like what they call frequent flyers, a lot of dismissive language of patients who keep coming back to emergency departments. Emergency departments are big windows into our society. You know, we heard this from the community. But the idea of trying to understand how is a hospital engaging with the community, in what way, becomes important. Other examples of this, by the way, would be things like parking lots and, you know, different ways in which communities clash or work together. Architectures of disengagement. One of the things that I've been talking with some folks here about that I want to call your attention to is many American hospitals are beautiful places. I mean, these are huge money, big glass structures, and the hospitals are super proud of their major developments, right? They're constantly applying for architecture awards and winning them sometimes, and landscaping and all this stuff. And you kind of, you know, but what we learned was that if you talk to community members, they're often feeling as though the campus was built for the campus. It's an inward-looking thing. So people would point out, you know, well, why is that parking garage the front face of that campus? Well, the campus might be internal, but the community on the outside feels blocked out and off-put by these things. So clearly, the modern fad, or the focus that hospital administrators have when they get huge endowments to build a new wing or something like that, is a focus on architectural wonder, but it often has the opposite effect on local communities of making them feel even further away. Also, just, you know, if you're living in a small house and you're, you know, a working class person whose kid goes to school down the road or whatever, that's not going to be a welcoming place. And the idea of developing hospitals in ways, designing them in ways that are welcoming to communities is not something most hospital systems have thought about. Sometimes they say they have, but actually it's pretty clear when you ask them, well, what did you do to talk to the community? They didn't do, again, to that theme from before, they didn't do that kind of hard community work of sitting at tables together and talking. Anchor institutions. I don't know why that popped up top, but there it is. You've probably heard of this idea. An anchor institution is a concept that's been around for a few decades now. It's this idea that there are some entities within cities and towns that are never going anywhere. Most likely, and I did mention some hospitals move, that's a big deal, right? But in general, right, I mean here in Williamsburg, right? William & Mary is clearly one of these institutions. You're here. William & Mary can't just say, hey, we're thinking of moving to Richmond, right? You could, but it's not really credible. Now, what happens with a lot of these institutions is they do, and I'm not talking about William & Mary now, but I'm talking about, there are entities that will say, like Nationwide Insurance in Columbus, Ohio, for example, a huge corporate headquarters. We're really lucky to have them because they do employ a lot of people. Every couple of years, they come to the city and they say, we're thinking of moving to Indiana. What can you give us? And they can give them tax exemptions. They can give them money to build a thing. This is a multi-billion-dollar for-profit insurance company, and they're shaking down the city of Columbus to get a better deal. Hospitals do things like this. Schools do things like this. Sports teams are the one you probably hear about the most, right? The Phoenix Coyotes, the Arizona Coyotes couldn't shake down the city anymore, and they ended up moving to Utah. Right, this is going on with the athletics leaving and baseball leaving Oakland and maybe going to Las Vegas, but there are conversations taking place. So large entities can threaten to move and extract resources. And I already mentioned that resources can already be a little bit tight, right? But in general, the idea is you are here. Ohio State is in Columbus, Ohio. You're not going anywhere. Figure out how to fix some of the problems in the communities. Work with us if you're going to commit to this place. And hospitals are similar. Rethink of rankings. I mentioned this before, but I do want to just punctuate it one more time. Hospitals are extremely proud of their rankings. like it's a little bit of a paradox. I remember sitting with somebody at a cafe in Aurora, Colorado, talking, and they were really upset about some aspects of the hospital's engagement with the community. But right there is a big draped thing across the street, number one in this and number one in that, and it's a little bit off-putting to community members, especially in poor communities, especially in working class communities, where they look at these structures but feel like that might as well be 150 miles away, because it actually is not doing anything to affect their health. It's not doing anything to encourage population health improvement, right? So rankings don't tell us much. Now, I will say some of the large rankings out there, and I've written a few popular pieces on this. Every time the rankings come out, I think about whether I should write another piece. But some of these rankings are now including community engagement increasingly, and that's something I think could be cool to see happen more and more. Is not that you're just number one in some kind of high-end robotic surgery or something, but that you've actually improved diabetes in local communities, and obviously coming up with the metrics for that would be a question. Buy, live, and work local initiatives. So these include things, and these are interesting, and I do encourage you, especially those of you who go to other places, or if you're here in Williamsburg and you meet somebody from these hospital systems. In large urban environments, especially, there's increasing pressure to buy from local purveyors and local companies. Hospitals require a lot of resources, from toilet paper to gowns to paper to food, all sorts of things that are often made locally, but often not purchased locally. Right. So using that, and then there's also pressure, especially thinking about health inequities, racialized health inequities. Can you, and the Cleveland Clinic's doing some of this, can you buy from businesses run by people of color, right? Can you look to organizations that do good work in the community or businesses that have other commitments and support them? And you're seeing some of these programs. The Cleveland Clinic has a fairly large effort in this regard. One of the things we couldn't really get much data or a straight answer on what kind of effects it's had. The metrics and the assessment and the measurement can be a little elusive, but it's happening. Working similarly, hiring people from local communities, and not just in the lowest paying jobs, but maybe across the board, or doing training to help people to become positioned to work for hospitals, because oftentimes, and this is to the last piece on living, the vast majority of the high-end folks who work at hospitals are elites who drive into the suburb, leave the hospital. So they come in the morning, they park, they eat in the cafeteria, or they bag lunch, and then they leave and they go back home to the suburbs. But the idea of people actually living where they work and recruiting people who will live in local communities is something that most of these places struggle with. I want to make one comment about that too, which is that I was telling you a story earlier. Sorry, let me go back here. Oh, I guess it doesn't go back. There we go. When the Anschutz Medical Campus was being built, they were talking, the University of Colorado was holding meetings with local businesses saying, hey, we're bringing in tens of thousands of people here. Get your businesses ready. Literally like going to restaurants and telling them to start making them a little nicer because the clientele they're not gonna like eat in a place like this, but if you can, we met with restaurant owners who had these meetings, but what ended up happening is that they came in and parking was so tight that you get your parking spot, you don't want to ever give up your parking spot. So they weren't ever leaving the hospital campus to go eat, first of all. But more than that, the hospital built a huge cafeteria where everybody goes to eat. So all these local businesses have been talked about how this is going to be an amazing thing for the community, and very, very little ever went back into any of those local establishments. In fact, the one business owner that we talk about the most in the book, that business closed. Right. So but of course that was a pre-COVID story, so there's more to it. but it's important to think a little bit about promises that were made, the way we think about what's going to happen. I always think about, again, the sports stadium thing. There's how many football games a year in the NFL? Like, I don't know. Like you play like 9, 10 home games max, something like that. That's not a ton of economic infusion into local areas when you think across the year. And what do you think about millions of dollars of taxpayer money going into this? That doesn't seem like a good deal, and I think it's pretty well demonstrated that it's not. But anyway, I don't want to get off on a sports tangent. We're supposed to talk about hospitals. And they do a lot of community health engagement. You find a lot of hospitals are doing mobile clinics. They're doing pop-up events. They've established community health centers that are quite vibrant. And there's more to say about it that I don't have time to get into right now, but some of them do a lot of good, and some of them seem to miss the mark, right? But there is increasingly an effort to try to do this. Okay. Just a few more minutes here. So one of the things that I want to talk about is just expectations. Because I'll say, when you ask people, well, what are hospitals doing for your community? The average person you speak to says, why should the hospital do anything for our community? Which is kind of interesting because Congress has already said that they should be. People who understand hospital financing know how much money is at stake, and they also understand the deficit, what the Lown Institute calls the fair share deficit, which is they're getting this in tax breaks and they're giving back this, and the fair share deficit, the assumption is that should be roughly equivalent. But in general, and I think that I don't want to get on a soapbox here about politics, but our society has kind of come to expect less of our institutions and come to expect less of ourselves. And, whether it's do you vote or it's, what do we expect from our Congress or what do we expect from our schools? And what we found talking to people about expectations is, first of all, they expect that hospitals are going to be places where great clinical work is done. Now, I put education here. This is not something that came out of the community, but what the hospitals tell us is we do tons for the community. We train doctors here. We develop research. But the development of high-end research doesn't necessarily mean anything to local communities. The training of doctors doesn't even mean anything to local communities. My students train in these places. They don't have to stay there. They don't have to live there. They don't have to become part of the community. In fact, my students, whether it's in their 3rd and 4th year rotations or it's in their residency, they're the same people who drive in, park, eat in the cafeteria, and leave. Right? So while the hospitals will say, look, we are investing a lot in this and we should get credit for this stuff, there's a disconnect in terms of what that means from a community health perspective. The community does expect access to good healthcare services. They expect to be treated with kindness and cultural sensitivity when they go into the emergency department. They expect linguistic competency. They expect that they will not be treated disrespectfully because they are not big paying, well-to-do folks. They're local community members. Now that's an area where it depends on your engagement with the hospital, whether people feel that way or they don't. They expect them to be a good neighbor. Now, being a good neighbor as a hospital is a lot harder than you would think. There are tons of cars coming into hospitals. There are ambulances constantly coming into hospitals. There are helicopters that are pretty loud, right? And then also I mentioned the expansion and contraction sort of piece of things. So just being a good neighbor is more difficult than you might imagine. But it is something that people say, like, at a minimum, I want to be able to sleep at night, or I want to know that, like, if I needed something, they'd be there, or these kinds of things. And then there's the question of what Congress now requires, or has for some time, of actively improving communities. And I will tell you, the average resident doesn't expect anything from them. Now, sometimes it's because they don't know, the full financial scope of things and all of that. Sometimes it's because, and this is a sad thing, but They don't expect anything of anybody. These are communities that have been forgotten for a long time. They feel like the government doesn't care about them. Why would anybody do anything? They've kind of had to fend for themselves, right? They don't trust the police. They don't trust local, businesses necessarily. So there's like just a lack of expectations generally that I think underpins a lot of this. So even writing a book about talking about what hospitals should be doing is kind of like already putting me in the idealistic category of, expecting anything from anybody. Compensating for governance failures is an interesting one. One of the things that will happen when we meet with some of the hospital folks is they'll say, these community members are just totally unreasonable. They think we should be, we were told, I think it's in the book, in the Cleveland Clinic, somebody said, they think we should be filling potholes. That's the government's job. And I'm like, well, there's tons, you guys are a major cause of traffic all around here. You have your emergency vehicles driving through the streets. Like, why shouldn't you fill hospitals if the city of Cleveland it doesn't have the resources to do it? And also you could ask the question, well, if the Cleveland Clinic was paying, a full tax load, and I'm not advocating for that, by the way, I'm just raising the question, but maybe they could afford to have adequate staff to fill potholes. But there's this kind of back and forth of like, we couldn't possibly make up for the failures of governance. Well, maybe that's legitimate, but it certainly points to a bigger conversation of what we're talking about here, when we're not just talking about kind of allowing a small little hospital to kind of do their job, but we're talking about large-scale entities with multi-billion-dollar bottom lines. And then, as I mentioned, expectations for many people is just nothing. And to me, that makes me sad. We could think of other places where we've come to expect very little of institutions. And I do think running through this book, as a political scientist especially, we think about institutions like governance, or state, local, county government, public health, right? What do we expect? Public health is a pretty wild one. A couple of years out of COVID now here, where I can think about the fact that almost nobody knew about public health at all. All of a sudden, like in Ohio, our public health director was on TV every day. And people started having expectations, but before that, they weren't really thinking about who's watching our water quality, who's making sure that foodborne illness is being addressed, or these kinds of things. Everybody loves to complain about air travel, and air travel can be super annoying. I wonder, I find it miraculous. We haven't had a passenger airline crash in the United States, a large one anyway, in many, many years. Right? Growing up in the 80s, it was pretty common. Right? The FAA does good work, but we only care about the FAA when something goes wrong. And there's a kind of paradox of governance where if we can start to look at our institutions and care for them, then maybe we can get ahead of these things. But we're in a bad place right now, I think, with these kinds of expectations. All right, let me just move through this quickly here. And I'd love to talk with you for a few minutes. We end the book with a couple policy prescriptions, and I'll say this is not an exhaustive list. It's not even the most well thought out list in some ways. These are ideas that I think, as a policy person, I always try to tell the policy students I work with that one of the keys to policy in the United States right now is we need creativity. We need some courage of ridiculous ideas, throw our ridiculous ideas out there and see but we need some creativity. So we're trying to think about how we can leverage existing resources, but also maybe put in some new ones. And the first one is EMTALA. And I mentioned the Emergency Medical Treatment and Labor Act before, 1986. I've told you why I think EMTALA is so important. I don't want to use EMTALA for everything, but it is a kind of interesting thing that if those of you who've studied American government and federalism, kind of the only way you can get states and local municipalities to do things is by leveraging the power of federal funding. And federal funding through Medicare is a powerful source. By the way, federal funding through Medicare, a lot of it's for medical education. I don't know if you all know, those of you who want to go on to become medical students, you'll find out that your residency program is most likely going to be paid through the Medicare system. Right? That's how we do it. For weird reasons, you can read about that history, but that's how we do it. Well, if the federal government's going to be paying for medical residents, can't we shape medical education a little bit? Can't we get residents out in the community? Can't we start thinking in a little bit more of a preventive and a public health mindedness framework? Can't we start doing work around implicit bias and anti-racism? Right? Like, we should be able to leverage that, but we haven't really to this date. They kind of just give the money over to the programs, and then independent, professional organizations oversee the whole thing. Second, rethinking graduate medical education, the second piece, right? So you can leverage EMTALA for all sorts of things, but I think as we're thinking about changing medicine, one of the things we need to do is we need to change the way healthcare professionals think about all this as they're becoming healthcare professionals. I adore my students. I respect them. I think they're super smart and they make great physicians, and I know that. We have evidence of that. But what we need is for students in medicine and nursing and clinicians of all sorts to think of themselves as a public health mobilization. And right now we're still training future healthcare professionals to kind of be little siloed individuals, many of whom are constantly fighting for autonomy instead of learning how to work in teams. So I would like to see that happen more. But one of the things that I tell my students, and those of you who want to go on to medical school, maybe in 4 or 5 or whatever years you'll remember this, but call me if you don't, is I always tell my students when they're on their way to residency, I send them a little link with some GIS mapping on epidemiological data of the communities around. I tell them, like, take a walk. Go and meet, go to a church spaghetti dinner and just talk to people. Like, spend some time learning about the community you're working in, because residency life can be, 72 hours on the floor, sleeping, in cots and stuff. Once you're in it, you're just in this space. And you forget that actually what you're doing is working with populations that are living outside and down the road. Third, respecifying community benefit and IRS rules and oversight. I mean, this sounds like a basic one. I mentioned that the Obama administration took a big whack with community benefit. I think it's a really important development, but they underspecified it to such a point that it's not clear what's being gained always. And I'm not the only one saying this. And one of the big names in all this is Senator Chuck Grassley from Iowa, Republican, very powerful senator, been around for a long time. And he says, I think we have pretty good legislation, which is pretty funny, right? Because I'm sure he voted against the Affordable Care Act. This is always funny, right? People who rail against things and then celebrate them later, like a Congress member who votes against an infrastructure bill and then gets there for the ribbon cutting at a new bridge, I think we have pretty good legislation, but it's up to the IRS to enforce it and to deny hospitals, and to deny hospitals tax-exempt status if they're not doing their job. If you do that once, you're going to send a message to the whole profession, and that'll straighten things out. So it's actually not entirely true. I mean, it is up to the IRS to enforce it, but I'm going to call Senator Grassley out a little bit here and say, a lot of people have been attacking the IRS for a long time. Whenever the IRS tries to strengthen some rules or fund some new oversight, they immediately get dragged through a political fight. So it's a little disingenuous to say the IRS should just enforce things. By the way, you probably know that we just went through a period where the IRS was just trying to, President Biden was trying to fund the IRS to just do its basic job, and that didn't even go so well. So, but it is clear, and there is bipartisan interest in this issue. It's a big lift. And the fact that it needs to go through the IRS makes it politically thorny. Fourth, there's 6 of these. Transparency and accountability by state and local government. I mean, this is a very basic one, which is that every hospital has their community health needs assessment and their plan on the website. They should, by law. So you can go to your local hospital if it's a nonprofit and read their report, right? But still, transparency in terms of what they're actually being done, transparency in terms of what they're charging for their clinical services, transparency in terms of what kind of aggressive debt tactics, recovery tactics they have. Remember, the Affordable Care Act says you're not allowed to go after people in overly aggressive ways. Part of being a nonprofit is eating some of this sometimes for community benefit. Right? So, but clearly, as I mentioned, hospitals, the last thing I'm going to call them is transparent. Re-envisioning space. A lot of hospitals are going to be developing over the next decade or two. It'd be really nice to see more hospitals think about the way in which their space opens up into communities, talk to communities about the design of them, stop worrying about high-end architecture awards, and start thinking about access points, ways to retain local communities and support them instead of knocking down buildings and putting up a parking garage or that kind of thing. Just be more genuinely collaborative, but not collaborative in a coercive way where you say, hey, we already have this plan that we paid an architecture firm to develop. It's basically done, but we want to get your feedback on it, which is what appears to happen a lot. And finally, campus reporting. One of the things that we talk about, and if you know the Clary Act from 1990, this is, I'm sure, William & Mary, every university and college is subject to this federally. Real transparent reporting of crime and other situations on campus. This also includes abuse from medical professionals on campus that oftentimes just goes into a medical board rabbit hole and doesn't get a lot of attention, but a little bit more openness about the kinds of things that happen on campus and safety and just the general conditions is something we think would be worth exploring. But you might have other ideas, so I would love to hear them. And thank you. And before question and answer, I just want to reiterate what I said at the beginning, which is don't hesitate to email me. I think, obviously, if anybody's even halfway interested in this work, you're my people. So I would love to hear from you. And thanks for your attention. Yeah, we have a microphone here. You can.
Really appreciated your remarks. I wanted to ask you a question, but before I did, I've spent many years on the staff of the City Hospital of San Francisco, and it may be a little different than the three hospitals you used in your study, in that within a few years of the gold rush, it was the flagship of the City Department of Health. And it was different perhaps in that way than the other three institutions. Examples being there was a point at which the surgery department running a level 1 trauma center, which means they get the most serious trauma problems, wanted a heliport, and the community was actively surveyed, said there are too many issues with that, and it was dropped. On the other hand, in 2008, when we had a terrible economic downturn, they asked the citizens of the city to support an $800 million bond measure. And it just seemed crazy and upwind to try and get that passed. And yet it passed by a margin of about 84%. Extraordinary.
Yeah.
So, it shows you two of the aspects of being an actual city institution. I also would be curious about your comments in terms of the devitalization of hospitals taken over by venture capital and the socioeconomic impacts of that. And lastly, your second point of the list of very interesting ones about graduate medical education. We've had now 20 years since the professionalism charter indicated that physicians and other professionals should be, one of the pillars should be social justice. And I'm not personally very encouraged, nor are some of my physician friends, about where we've gotten with that.
Yeah. No, it's great. There's a lot in there. Thank you very much. I hope I can hit all the points. But I don't know enough about the San Francisco. I guess I have one follow-up, which is that a standalone hospital, or is that now part of a system?
It is still standalone in the sense of affiliation with the city.
Yeah.
Well, no. It did affiliate with the School of Medicine, UCSF.
Yeah.
But that was probably 80 years ago.
Yeah.
So that has been affiliation. And I would say that's an intrinsic issue because it's a hospital that has to reconcile the demands and requirements of the city health department with the School of Medicine.
Yeah. No, that's great. So and I don't know enough to give you a really vibrant answer on that. But I like the passing of levies and all of that is like, it really depends on the messaging and the campaigns that get behind them. So I would have to know more about that. But heliports can be a big deal, and obviously, especially for affluent communities with political power. Like, this is just like, the longer story of how garbage dumps end up where they end up, or where train tracks are. I mean, any kind of nuisance, any kind of noise, any kind of smell, like, we know how the NIMBYism works within that dynamic, and it doesn't sound that much different. I'm going to just mention your last point for a second. I have to think about the second one. But like the social justice piece, I'm actually pretty optimistic, and this is one of the moments where I become very much like, hey, I train medical students. This is awesome. It depends on your specialization, right? If you're going to go into a big money, high special, like in orthopedics or something, like there's not much of a taste for social justice or for any of that going on there. But the emergency medicine physicians have been enormously active in the gun violence discussions. In fact, their major organization took a big position on it, right? And I'm seeing more of that. Seeing a lot more from the pediatric world, in terms of climate discussions and certainly anti-racism. So I think there's a lot more justice and interest and activism amongst physician groups, and also within hospitals. I mean, some hospitals and residency programs are licensing, and they need to. It's okay. You can go out to the protests. You can go out to the march or whatever. Some of them forget it. But I think it's highly dependent on the kind of culture around, and I think it's really different if you're, depending on what kind of specialization you're. Family medicine folks, they have a lot of license, but it does stratify along, I think, the economics of it. And I'm sorry, and your second question, can you just,
yeah. It had to do with venture capital.
Oh, venture capital, oh my God, yeah. I mean, it's horrendous. I mean, there's nonprofit systems that are huge and are ever growing, and then there's the buying up of some of these places and converting them to for-profits. And clearly, there's a good book I can just point you to. It's I can send it to you if you want me to. But a good book on the role of private equity in healthcare. And at the end of the day, it's just that private venture capital equity, they don't care about health. It's another commodity, and I think that's kind of the truth, Other questions? Yes, you want the mic? Oh, we have one back here. Yeah.
Thanks so much for your talk. I love the premise of this book. It's great. My question is about the word community. So community can be this really vacuous word that means a lot of different things to different people depending on how they want to deploy it. So I'm wondering how the hospitals themselves go about defining who the community is.
Yeah.
Who constitutes the community? Is it the neighborhood that they're actually locally embedded in? Do they mean the city? Do they mean populations?
Yeah.
And how, if at all, did that vary across your case sites?
Yeah, thank you for that. And I should have put that in the presentation. I was trying not to overburden everybody. But so one of the things is that the Affordable Care Act and the IRS regulations allows hospitals to define community as they see fit. So is the Cleveland Clinic's community global? And they can just look past Huff and Fairfax and, we went on a tour there, we talk about it in the book, and they're like, here's where Robin Williams stayed, here's where Oprah stayed, and here's where, this king stayed, and we're like, that's cool. But you can literally look out and see entrenched poverty out the window. So community is a shifting thing. They need to kind of define it. You can also define community around certain kinds of groups of people, asthma or disease classifications, things like that. So again, this is another area where I think anybody looking at this says we need to get a consensus on what we're talking about with community here. And as I mentioned, the University of Colorado, a 5-state Rocky Mountain region, what's the community here exactly? And by the way, I just have to say, since some of you may have thought of this, yes, we're talking about the same Aurora that's been in the news lately with former President Trump talking about these groups, gangs and such. Aurora is an extremely diverse immigrant population. And, I went for a walk with the sheriff of the county, and he said, yeah, we don't worry about immigration status because we're trying to keep people safe, right? So like, there's a real tension in some of these communities between like, just trying to improve people's lives, and then some people who want to turn it into a political project of being tough or whatever. But this sheriff, and sheriffs are not generally sort of feel-good, liberal, public healthy types, right? Was like, no, like I need people to come to me and tell me when there's something I need to know about, which means I don't care what your status is, I don't care anything. My job is to keep you safe. And I think that's a very pragmatic way to think about it. But yeah, you're right, the word community is bracketed very much here. Yeah. We had a question up here, I believe.
Hi, my name's Abhilasha. First, I want to congratulate you on a nice presentation.
Thank you.
So I'm currently writing a research paper about health disparities and like the driving factors behind them within different countries and within subregions within countries. So apart from like typical factors that you would see in contemporary research, like your race, your gender, socioeconomic status, population density, regime type, or like specific institutional policies, what do you think is the primary factor behind the health disparities that I guess is not so common to see in the literature today?
I think it is in the literature. I mean, this is one of the frustrating things about public health. Like, we need research. We need to discover new things, of course. But like the frustrating thing for me politically in the state of Ohio, I'm guessing Virginia does this too, is we know what the problems are. We even know what the drivers are. We have like no political will to actually address them, right? So it's poverty. I mean, it's not just poverty, it's segregation, which is linked to poverty. It's the way in which, I mean, you can ride a bike 10 minutes south of my house. I live in one of these places where professor types live, nice community, pretty affluent. 10 minutes south on a bike, and life expectancy drops 10 years. On a bike. I mean, and this is, I don't want to trash my city only. I want to trash almost every American city, because this is true almost everywhere, right? So it sounds like you were fishing for like another thing other than what, but that is the thing. It's like such a blunt answer, but it's so true. I don't know if you want to ask back to that or if that's satisfying, but, and this is true, by the way, globally. I mean, you find this in many places that we didn't even talk about the global piece today, so. Yeah. But I'm happy to follow up too, by the way, again, like please, feel free to be in touch.
Your question, one other thing I would add is if you compare male and female patients coming into systems, and they both present with chest discomfort, we now have solid evidence that the staff is much more inclined to see the male as perhaps suffering a heart attack and the woman having an acute anxiety episode. And in no way am I denigrating an acute anxiety episode, but my point is that part of the healthcare disparity that we in the healthcare professions have to acknowledge is our own biases, which are increasingly documented.
I mean, we spend a lot of time at our medical school, I'm proud to say, addressing racial and gender bias, and students often come into medical school at an age where they have bias about disability or sexuality, and we do our job in doing that. But certainly, health disparities in the United States are racially, ethnically, and otherwise stratified in a way that's just, I mean, it's a huge. I think we have only begun to understand how deep it goes and how hard it is to get out of this. And people think they can do some webinars and sort of train a few people here and there or whatever, sign a pledge not to be racist or, these kinds of, it's like, this is hard work ahead. And hospitals, I will say, are going through this. I mean, hospitals are also working on this, but man, our history is deep. I don't need to tell a bunch of people in Williamsburg, Virginia about that. That's my only colonial Williamsburg joke of the day. So.
We could maybe squeeze in one more question if anyone has one. All right, well, please join me in thanking Dr. Skinner again.
Thank you. Appreciate it.